Could have Mike and all the panelists come up now and take their seats here. So the way we designed this last session really is to use these two talks as a place to start the discussion about where do we go forward with the research. We want to talk about both HIV as well as viral hepatitis, and how can we take some of the lessons we have learned from treatment as prevention from one to the other, et cetera, and also hear from the federal agencies in terms of what some of the research funding is going to look like. So maybe the best thing to do is, you've both given us just incredibly good information to get the discussion going, but if we just kind of go down the panelists, and if each of you could just say what's at the top of your mind right now after hearing these two talks, maybe just a 2-minute opening statement, and then we will go from there. Henry, we'll start with you. And if you could just introduce yourself, it will be quicker than if we try and introduce everybody from here.
Okay. Henry Masur from the National Institutes of Health. I think that what Mike talked about in terms of prevention is really a testimony to the importance of leadership and vision, because clearly that effort on prevention wouldn't have happened unless Mike had advocated for that. I think what Kevin talked about in terms of new technologies for incentivizing people is also something that is a new vista for many of us. And I think it really emphasizes the fact that coming to a meeting like the Forum really provides an opportunity to look at different disciplines and see how we can apply them. One of the things that I've learned at the Forum over the years is that in Washington, we have become very envious of how many cities have developing and integrated programs, which Washington, D.C. has been way behind in. I've said at this meeting before, I've regurgitated the data that D.C. is #1 in terms of incidence of HIV, while there are other cities that vie for that honor. I think that one of the things we've learned here is that we really do need better leadership on all levels if we're going to solve the problem of HIV or HCV. I think in D.C. for many years we had a number of problems in terms of the city health department, in terms of the universities not being clearly linked to community health departments. I think that seeing what was happening in other cities led to renewed vigor in D.C. I know that Marsha Mason talked here before. I think in many ways she and Shannon Hayter really led a revolution in terms of the city health department. I think NIH has worked with the GW School of Public Health and with many community providers. And I think that in D.C., using ideas from meetings like this, there really is a renewed sense of vigor and community. But I think we also realize that if we're going to make progress, #1, we have to be linked so that the city health department, the federal government, and the universities and clinics need to work together. I think that is happening now in D.C., whereas it was not happening 5 years ago. I think that there were a number of presentations that emphasized the importance of data. By having a citywide data system, we think we'll be one of the few cities that will have a data system that will not just be based on one institution, but will really allow virtually all the providers to look at their data, to allow the city to look to see where are the programs that need enhancement so that they can improve their performance, not in a pejorative way, but to see where are we doing well, where do we need to do better. And I think there's also a renewed sense of working together so that we can do research not just to produce more academic projects, but so that we understand how the Washington, D.C. Experience is different, and there are some local differences, and how we can provide better access to new strategies. And we're very pleased that now, particularly in HCV, we are providing access that was not previously available to new strategies, and with the new directly acting agents, I think there is going to be a new era, which we hope we will not be way behind in the way we've been before, but we will be ahead of the curve. So again, I think this is a great meeting for looking at different operational practices. For many of us, doing operational research is very different from what we've ever done before, but I think that for for the reasons especially that Mike Cohen said. We have many of the pieces, now we have to decide how to apply it. The people in this room know that. I think many of the rest of us are here to learn that. And I think, again, the hope is that over the next decade, we really can apply that and see that our metrics for performance get better and better.
Thank you, Henry. Raymond, Daniel, if you introduce yourself, and again, just brief, just what's on the top of your mind right now.
I'm Daniel Raymond. I'm the policy director of the Harm Reduction Coalition, and I kept juxtaposing Mike's excellent nuanced talk with Cornelius Baker's caution this morning that when we're talking about biomedical interventions that we need to be attendant to the environmental context that either enables or creates barriers to them. And I think that amongst the community there's a lot of excitement about the potential of HIV treatment as prevention, but we need to continue to make sure that we're talking about it in a broader framework, that the biomedical side doesn't displace all of the historic conversations that we've had with more of a social justice lens, an emphasis on housing, on things like harm reduction and syringe access, on stigma, because those are going to be the externalities that make or break this intervention. I also think that, I remember, for example, from the previous International AIDS Conference in 2010, the Vienna Declaration, that we cannot end the AIDS epidemic without ending the criminalization of people who use drugs, and of course that extends to other populations. So I hope that in the spirit of this meeting, which brings together advocates, researchers, clinicians, health officials, and so forth, that we can continue to have that broad lens and we apply that to the really exciting developments. And then thinking about it in the hepatitis C context, we have some modeling studies from UK, from Australia, more recently from Vietnam, that suggest that treatment as prevention for hepatitis C would have an impact on the epidemic among people who inject drugs, which is really important because our best guess is that even if we were able to fully scale up our best approach to prevention among this population, which would be a combination of methadone and buprenorphine and syringe access, we'll only get part way in terms of eliminating transmission. So treatment as prevention would play a very important role. In this case, we do not have the correlate of community viral load for hepatitis C as an index. We don't have the kind of environmental studies that we've seen coming out of British Columbia, out of San Francisco, and other places. So I think one of the questions is, what would an HPPN 052 for hepatitis C transmission look like? And I think there we're talking about a very different kind of study. We're talking about a more social network rather than discordant couples. But if we, as a thought exercise, started to imagine designing and implementing that study, then I think that we could start to hone in on where we would really need to push some of the research and implementation for a hepatitis C corollary of treatment as prevention. But I just also want to acknowledge that in order to even think about getting there, we really need to address the diagnosis gap. You've heard throughout this conference about the concern around the USPSTF-C recommendation for testing of baby boomers. And I really want to encourage everyone here to continue to follow that discussion, talk to Ryan Clary of NVHR about how to get involved in advocacy around that. I think also we do have, as John Ward said earlier today, the promise of exciting new treatments that could be curative in 3 months and reduce the bottleneck that we see in interferon-based regimens. But to get there, I think that we need to make sure that the promise of these new treatments is accessible and realizable for all populations. And I think one of the cornerstones of actually rolling out the capacity to provide these treatments is going to be sustained attention to the activities in the Viral Hepatitis Action Plan, but also looking at the role, the critical role that the HHS Adult and Adolescent Antiretroviral Guidelines has played in the diffusion of quality care across different settings, across different providers. And this would be an important moment to galvanize some energy in terms of having a parallel HHS hepatitis C treatment guidelines panel. Thanks.
Thank you. David?
Dave Thomas from Johns Hopkins, and I'm here to represent a viral hepatitis perspective. And there's a lot that could be said. Most has been. I think my perspective is Hep C treatment is changing extremely rapidly, and the transformation is enormous at the bedside. The tolerability and the efficacy is just amazing, the difference compared to giving people interferon. I think the real question is, what are we going to do with that, and how we can certainly, I believe we can certainly prevent hepatitis C transmission by treatment. I don't think there'd be any question, because you can't transmit the virus when it's not there. And if you cure people, then they won't be transmitters anymore. So I know you would agree with that, Dan, and I get your point about the fact that we don't have enough knowledge to build those models completely yet. I think the real question, though, gets back to Kevin's talk. How do you get treatment? How do you complete the cascade? Expanding testing, I'm even somewhat optimistic that we'll be able to do that, though the battle with the recent C rating is clearly one worth fighting. I'm more concerned with how do you get someone with a asymptomatic infection who has a lot of other things to worry about to embrace care. Because even in some of the drug use presentations that were shown yesterday, half the individuals knew about their hepatitis C infection. They had been tested before and knew about it, but when you get down to the uptake of treatment, it's never above 5%. So that bit that Kevin went into, I think if there was one thing that I'd like to get my head around and be able to do better, it would be that, to figure out a way to motivate an individual with hepatitis C who has a lot else going on in his or her life to engage in treatment. So we need to definitely get the new medications on that essential list so that there aren't barriers to cost and some of those other factors. But I think even if we do all that well, we need to figure out a way to motivate folks to engage in treatment.
Okay, thank you very much. And unfortunately, Jack Halsa, who was so much looking forward to being here, is not able to be here today, but we have his colleague, Naresh Chand. If you could just make some comments in terms of your position at NIDA, in terms of what new grants are you going to fund, having heard these comments until now.
Well, thank you, Dr. Miller. It's honored to be here on behalf of Dr. Jack Khalsa, and I salute to all of you for your contributions to this field of infectious diseases which affects global populations. In terms of what we do, we fund translational clinical research on the medical consequences of drug abuse in HIV-infected people and co-infections. And medical consequences could be inflammation, fibrosis of liver, skin, kidneys, remodeling, and cardiometabolic consequences. And these are highly vulnerable populations, and we tend to support that translational clinical research. And I have a little one-page flyer here. If somebody's interested, I will be more than glad to pass it on to you, and you can pass it on to your colleagues and friends who are interested in pursuing medical consequences of drug abuse in co-infections. Thank you for your kindness to ask me to speak.
Okay, thank you very much. So let me ask John. You must have a lot that you would like to say, having heard these two talks and the comments having been made.
Well, am I giving another thing at the end of this?
Oh, yeah, the summary of the conference. This is just now on this session, you know, behavioral economics.
Okay, well, of course, I've already mentioned the fact that the guidelines in the United States say everybody should be treated. It's patently obvious. One-liner, and I think we've gone that way. To be fair, WHO says they plan to go there when they can afford it. The rest of the world is behind. Is that fair?
How can we get the behavioral economics into our research?
The behavioral economic, you're talking about what Kevin talked about? P4P4P. which means pay patients for performance. Now, the NIH commissioned a study of how we motivate people to be treated, and the committee that reviewed it refused to review P4P4P. P4P4P means pay patients for performance. And so when they take their medicine, but they achieve no detectable virus, they get a reward, a cash reward. And you know, when I ask audiences around the country if anybody does this, a lot of people do it, and they do it in Africa as well. You go to the clinic, you get a bag of groceries. And when we did it at the Moore Clinic, our clinic, the administration said, no, you can't do that. When we wanted to give them cash, but they let us give them a meal ticket. So we gave them a meal ticket to McDonald's. Probably not great for health, but it brought them to the, it did bring them to the clinic. And I can tell you the patient said, where's my meal ticket? Where's my meal ticket? So I think, and what Kevin had talked about is that this is something that we really need to think about, how to motivate patients to take medicine for a chronic disease. And you already mentioned it with heart disease and other chronic diseases. You can't get people to take their medicine. And certainly HIV is a victory. However, we're not doing very well, as you all know, and we've got to think of ways to improve that last step, and that is to keep people at no detectable virus. And I think the principles that he laid down are the foundation of one good way to achieve that goal.
So I think we have time to take maybe 1 or 2 questions from the audience. So while people get to the mic, let me just also go back to Mike and Kevin, having heard each other's presentation, and you mentioned HPPN getting into hepatitis C prevention research. Very brief, Mike, what is the first thing you would do?
First, I'm more worried about the Powerball. Let's come to the most important thing. As far as I know, and Henry said he bought a lot of Powerball tickets, and Dr. Volpp ruined the whole thing as far as I but being serious about it, no, I think that we at the PTN have not really pursued this opportunity sufficiently for a variety of reasons. You know, there's very guidelines of what we're supposed to do, but I think we have to discuss this with the NIH more fully and say, shouldn't we be looking at more hepatitis C opportunities? And when you say what's the first thing we do, I mean, probably in some of our international sites where co-infection is really very prevalent, like in China, for example, we really need to rethink our focus.
And Kevin, so I know you've participated in this one HPPN study and helped them design it, but if you had, you know, there's no barriers, no financial barriers, nothing, what would be the one study you would think that the HCV and the HIV community should pick up?
Well, hearing people talk, I'm actually struck by the fact that for hepatitis C, the immediate potential of this approach might actually be greater, because you can have time-limited treatments where if people are highly adherent, then they're cured and then they're no longer infectious. So you can even imagine scenarios where that could be very attractive to various commercial entities out of economic self-interest, where if you have an insured patient, it might make sense for you, the insurance company, to set up a program like that. I don't think they're going to do it on their own unless it's been empirically proven to work. But I think having, you know, really trying to bring together the wireless technologies and the potential for giving people ongoing frequent feedback, I think that really should be tested in this context.
One other thing, one thing I'm struck by, I've heard Kevin talk before, but this particular time I was struck by how rudimentary what we're doing in this field is relative to the way he's thinking about it. And this is what happens in fields. We bring a whole bunch of virologists here, they're going to think we don't know what we're doing. Kevin's work is really inspiring, and it's really, like, we're just at the infancy of thinking this through. So I do think the more social intercourse we have with his group is like incredibly important, because we're giving $71, for example, as a single cash payment is kind of something I think you would look at as very rudimentary compared to the ways, I'm not trying to criticize us, but you'd have a much broader concept, and that's very impressive. So
I think what we need to do is have maybe a full day meeting on this one topic. So we'll take 2, but please make them short. First microphone 2 and then microphone 3. Oh, we have microphone 1. But okay, so make them very short, please. We'll start 2, 3, and then 1.
Great.
We'll take all the 3 questions, and then we'll have the panel comment.
Great, thanks. I'm Andrew Forsyth. I work at HHS in the office that really is charged with implementing the national HIV strategy here in the U.S. for...
Can you speak more into the mic because we can hardly hear?
Yeah, sure. Is this better? So Andrew Forsyth from HHS, from the office that's implementing the strategy for HHS, and I mean the National HIV/AIDS strategy. 2 quick comments and a question. The quick comment is, Mike, thanks for your policy paper on treatment as prevention in health affairs. I'll take a look at that. I think that'll be very important for us to take a close look at. The second thing I would say is that coming from NIH to HHS to policy work, I have to say I've really had my eyes open to the work that the health departments do, particularly the health departments in Washington, D.C., which I would say rival just about what we'll see in almost any other country any other city in the country, Seattle, LA, New York. So I just want to respond to something that you raised earlier, Henry. I think there's great capacity here, and I'm really excited to see Alan Greenberg and others move forward in the ways that they are. But my question is for Kevin Volpp, and that is, a lot of the behavioral economics work really focuses on the behavior of individuals, the health-related behavior of individuals. As part of the strategy, we really need to improve collaboration and coordination across organizations. And in some cases, individuals, gatekeepers, for example, who are making key decisions. We know the medical homes model is something we want to go forward with, but there's resistance in various forms to that level of integration. What does behavioral economics, if anything, say or that can help us think about how to incentivize better integration across the different parts of the government to provide better level care to people with HIV and HCV?
Okay, microphone 3.
Well, that was covering a great deal what I wanted to say, but I wanted to say it a little bit more simply. And to John, it's like, how about paying physicians and providers for implementing testing, and for us not to only put this onus on the patients, but also put the responsibility on the physician or the clinician in the agency themselves, bringing in the risk management, bringing in the administrators, and giving them incentives and exploring what are the disincentives for them of identifying new infections, whether it's HIV or HCV. And lastly, oh darn it, escaped me, but thank you.
Thank you, Jenny. Microphone 1, quick.
Hi, I'm Kimberly Page from UC San Francisco. I want to acknowledge the committee for bringing hepatitis C into the dialogue. I think it was really important. Understanding the sort of focus of this conference being strategy and implementation, I'm really glad. I think that the focus on hepatitis C testing is great. All of the focus here on hepatitis C has been on testing and treatment. Every single bit of it. There hasn't been one bit on HCV prevention. There's a real lack of knowledge about how to implement real prevention programs with the tools that we have, and we don't have enough tools. There is a lack of real political will to implement what we have, and I think that we in this group need to do better here, including how to get people into new technologies. We had a poster here and a talk about a hepatitis C vaccine. There was not one question from this group about a vaccine for people who need it for hepatitis C. Not one question. And I want to say, and my question and my comment to the group is, can you see a way forward to, the only person who acknowledged really the need for prevention here was John Ward with the CDC. Is, can you really acknowledge the need to move forward in this area and not bind it up with HIV? Not every hepatitis C dollar needs to be bound up with HIV dollars. And can you guys really embrace that challenge as we move forward? Thank you.
Okay, thank you very much. So let's go to Kevin first. Individuals versus organizations, patients versus providers.
Yeah, so the question about how to think about making it more likely for governmental organizations to work together as opposed to working in parallel is an interesting one. In many ways, decision makers at various levels behave just like individual humans and are susceptible to the same decision errors. And so a lot of that relates to time horizon issues, but there's a number of approaches to think about. One is to really think about changing the underlying choice architecture so that instead of operating like separate units, there's shared goals that are being measured and that people are being, or organizations are being held accountable for. You know, really trying to think about how do you change what those milestones are and how do you change the recognition and rewards that come with that. So I think the other key piece is really trying to think about just ways to make it easier, because when it's more difficult one path versus another, most people logically will choose the path that's easier to move forward on or that they're more comfortable with.
Thank you very much. And regarding the last comment, I think your point is very well taken. This conference was very much abstract driven, so we look forward to you connecting with the people in your networks that if the summit happens again in 2 years' time, we have much more abstracts on prevention and vaccines and et cetera. And certainly the organizing committee will take your comments in looking forward to planning for the next meeting. And I think with that, we really do have to close the session because we still have to just finish the summit, and I will just not take too long. So while we thank the panelists and the speakers once more, I'll ask Ken to come up, and I'll ask my slides to be put up, and we will then officially close the summit. Thank you.